Hi, this is Dr. Jennifer Engels from We Care Frisco. I'm here for our monthly webinar, and today's topic is sleep and how it's the foundational pillar of health. I'm interviewing Dr. Sahil Chopra from Empower Sleep.
Thanks, Dr. Engels. Hi, everybody. My name is Sahil. I'm one of the sleep physicians here at Empower Sleep. By training, I'm an internist. I specialized in pulmonary and critical care medicine, and then eventually decided to specialize in sleep. I've had the opportunity to train across multiple institutions from UCLA to Loma Linda to Harvard, and thanks for having me today.
Well, I wanted to have you on because I think sleep is so important, and I have a hard time convincing people in my clinic that they need a sleep study because a lot of them say, I don't want a sleep study because I don't want to go on CPAP. But I just want you to explain all the other reasons why we need to understand somebody's sleep architecture and how critical that is for health and prevention and everything. So, can you tell us a little more about the connection between sleep apnea, heart disease, and hypertension and other preventable diseases?
Yeah, that's a very loaded question.
Yeah.
But I think a better way to think about this is when you order a liver function test for a patient, you're just trying to get a basic analysis of what's the health of this person's liver from a bilirubin, AST, ALT, albumin, protein standpoint. And like how well of a job is the liver doing at metabolizing these things? So you're basically measuring the physiology of someone's liver with a liver function test. A sleep study is the same way. We sometimes think that a sleep study is like a sleep apnea test, but that's not what it really is designed to be. A sleep study is just a measurement of someone's physiology during sleep, and it's just a way to measure the health of somebody's sleep. And that's it. It's kind of like a chest x-ray is not a pneumonia test.
Yeah.
It's just a chest x-ray.
Right.
Similarly, a sleep test is not a sleep apnea test. You can identify sleep apnea, you can identify periodic limb movement, you can identify sleepwalking, sleep talking, all these other things, but it's just a measurement of someone's like health during
Right.
sleep.
Okay. And so, what's the connection between undiagnosed sleep apnea and high blood pressure or other conditions like that?
There's a lot of connections, and I think this will make more sense if we take a step back. Sleep is like the housekeeping process for our physiology. And if that housekeeping process for our body, our physiology, is interrupted, short, broken, unhealthy, then it starts to make sense why people who don't sleep well have a host of downstream consequences. From a cardiovascular standpoint, hypertension is one possible consequence of people who don't sleep well. People who have insomnia have a higher risk of having premature coronary artery disease. People who have chronic insomnia, people who have chronic sleep apnea, they're at a higher risk of having hypertension, atrial fibrillation. People who have sleep apnea are at a higher risk of having dementia, cognitive impairment, Parkinson's disease, stroke. And these are not like saying there's a slight elevation in risk of developing these problems over time, but rather like there's almost a 3 to 6 fold increased risk of developing AFib, hypertension, and a stroke, which are all very horrible things for one to have. And if someone's really interested in their health span, lifespan, marginal decade, all of these things that patients in like practice now are interested in, then making sure that somebody has very healthy sleep is a critical component of that.
Right. And do you find that sleep apnea can raise your cortisol levels and maybe contribute to weight loss resistance and problems like that?
Yeah, it can. And I think there's a lot to unpack there because when someone has severe sleep apnea, they are working hard to breathe during the night. So there is more calorie expenditure that happens, although that's not an healthy form of calorie expenditure. So if you treat someone's sleep apnea, some people gain weight, some people lose weight. And I think the devil's in the details. People who can lose weight are people who were initially fatigued, tired, did not have the motivation to exercise. They had dysregulation of hormones that control satiety, like leptin and ghrelin. And you correct that, and now they can make better food choices, they have more energy, and they can exercise and they can lose weight. All right, so that's like one sort of pathway. The other pathway is in someone who may not necessarily lose weight because they were already like not obese or overweight to begin with, and like putting them on CPAP or any other solution for sleep apnea did not necessarily make a difference. So I think the weight loss connection from a cortisol standpoint, anything that increases our stress during this opportunity of sleep can cause a higher level of cortisol in the morning time. So I think like cortisol is a non-specific stress marker, and sleep apnea, insomnia, poor sleep, that can easily cause that to rise. And it should, in theory, be lower if someone's sleep is better.
Right, right. And then for people that have mild or moderate sleep apnea, what are some of the non-invasive treatment options? Like instead of going straight to CPAP, what are some of the other options?
Yeah, there's many. And, the way I try to invite patients to think about this is a few decades ago, if someone had diabetes, that kind of equaled insulin. And now we are better at understanding there's different medications, whether it's metformin category or sulfonylureas or these GLP-1s, and that list goes on and on. And similarly in sleep medicine, there's been a sort of influx of newer modalities to treat sleep disorders, sleep apnea being one of them. And if someone has mild sleep apnea, mild to moderate sleep apnea, things that modify body position, things that modify healthier breathing with their nasal like nasal strips, whether nose dilators that are internal or external, tongue exercises, mouth tape, dental appliances, weight loss, surgeries, all of these things can be potentially tried. And I think what it comes down to is trying to figure out in a history or from a sleep study what's the root cause of sleep apnea. If we identify like where's that bottleneck in airflow that's happening, if it is like obstructive sleep apnea, then fixing that bottleneck accordingly with whatever modality can really solve the problem for some people.
Well, I know for myself, I tracked my sleep for a month, and some of the nights I was having moderate sleep apnea, which was kind of a surprise because I'm not aware that I snore, and I was kind of shocked at some of the scores I was getting. And so I used one of the interventions, which is the intake nasal strip, and my sleep scores significantly improved with just that one change.
Yeah, it's pretty remarkable. One of the things that I'll have patients do in clinic is called the coddle maneuver, where you have them like pull their cheeks to the side, and you just can see like, hey, when my nares are pulled laterally to the side, can I breathe better? And if that's the case, then it's possible that any obstruction of the nasal passages could be a contributing factor to snoring and sleep apnea. And these intake nasal strips can work. And intake, there's many different kinds, but they can work really well. Yeah, if you're curious, I have it pulled up here if you wanted to see it.
Yeah.
Just for the audience here to get them oriented, this top screen here is data from sleep testing. One of the unique things that we can now do is multiple nights of sleep testing. So this is a 90-day view of someone's sleep testing data. This purple line graph represents sleep quality across time, and this orangish bar graph represents the sleep apnea index, like number of pauses in breathing per hour that night. And you can see the first month, this number varied from like 5 events per hour to up to like 16, 17 events per hour. Most of them were in the low double digits, high single digits. And when Dr. Engels used these nasal strips, you can see that there was an immediate reduction in the number of events per hour, and it was pretty sustained across the night. And your sleep quality towards the end of this was much higher than it was in the beginning. So this is a unique situation, which doesn't always happen. We sometimes assume that if I address sleep apnea, my sleep quality will get better. That's an assumption, and that doesn't always happen. In your situation, that did happen, and which is pretty amazing that just by improving your nasal breathing, reducing the burden of sleep apnea, your apnea burden went down, the number of drops in oxygenation, they went away, and your quality of sleep jumped up higher.
Yeah, that is amazing. Can you talk about some of the other interventions, like maybe the bongo or some of the pillows and different things that y'all have?
Yeah, so the thought process here is, can I mitigate the effects of gravity on the airway to prevent less collapse and less pauses in breathing? That's the idea. That's like sort of the framework here. So there are many pillows that can help you stay on your side. For someone who's not used to sleeping on their side, it's very easy for them to say that I start sleeping on my side and then eventually I end up going on my back. And they're in sleep and they may not be aware of it. Their partners are aware of it, but they are not. So there are pillows that have been designed to help people sleep on their side. And then there's pillows that have a wedge. So when we increase the head end of the bed a little bit, 3 inches, 6 inches, 9 inches, that reduces the effects of gravity on the upper airway, and that can reduce the burden of snoring and sleep apnea as well. Those are all body positioning techniques. What you were referring to from, you said you use this term called a bongo.
Right.
The bongo is it stands for EPAP, expiratory positive airway pressure. So it's basically you breathe through this little device that goes in your nose, and then when you exhale, there's sort of like a valve that makes it harder to exhale on your way out. And by doing that, it creates a positive airway pressure in the upper airway to prevent it from collapsing with the next inspiratory cycle.
Okay.
So, CPAP stands for continuous positive airway pressure. It's like a reverse vacuum. It blows air in to keep the airway open in a continuous fashion. EPAP, which is this bongo type of device, stands for expiratory positive airway pressure. And it's basically that patient themselves is creating, it's kind of like pinching your nose when you exhale a little bit. And when you do that, you create a little bit of extra back pressure in the airway that prevents the airway from collapsing in the next inspiratory cycle.
Okay. So these are all things people could try instead of going straight to CPAP, as long as they don't have severe sleep apnea, right?
Yeah, we saw a patient today who had sort of mild to moderate apnea, but they had a ton of what's called fragmentation of their sleep. There was just a ton of like micro arousals in the middle of the night. Sleep was a little bit choppy, and they did really well with bongo. They put, you can see their sleep kind of transform with the use of this modality, and it was just enough back pressure to keep the airway open, prevent it from collapsing, and it solved their problem. So there's a lot of tools available. It's hard to know what's going to work and what's not going to work. So testing, trying, iterating, troubleshooting, iterating is like, it's kind of a process to get someone into like a journey of, or into a place of significantly better sleep.
So can you tell us a little bit about your sleep image ring that your company developed, and how that's different than doing a one night sleep test?
Yeah, a full disclosure, I wish I was intelligent enough to develop the sleep image ring. It looks something like this. It's not something that we've developed. It's an off-the-shelf tool. It was developed by my mentor at Harvard in the sleep medicine program, and it's been around for probably under a decade. And one of the things is enabled its usage to happen in a continuous fashion, where traditionally a sleep lab or a clinic might use this for 1 night or 2 night or 3 nights, maximum. What we do is we say, Mr. John Doe, here's a ring, keep it, test on an ongoing basis. And we built algorithms so that patients can see their results in real time the next day. So instead of having to wait, 1 week or 2 week or 3 weeks to get the results from a sleep clinic or a doctor, patients in the app can see their results similar to how they see their results from an Aura Ring or an Apple Watch or a Garmin, sort of in real time the next day.
So it's kind of like a continuous glucose monitor, but for sleep.
Yeah, absolutely. Or like an Aura Ring 3.0. It's
Right.
like it's a medical grade diagnostic device that can also be used for tracking, and it tells us like a lot of high resolution stuff about someone's sleep, movement, breathing, heart rate, sleep architecture, fragmentation, all of these interesting things.
Well, one thing when I try to tell patients about the sleep image ring and how I want them to do it for 30 days, they tell me that they already have an aura and the aura is telling them their sleep's okay, so they don't feel like they need it. But haven't you seen patients where the aura might say that they're okay, but then you're finding sleep apnea? Like, kind of in my case, my sleep scores weren't great, but I didn't know it was because of sleep apnea. So I
Yeah,
just want people to understand that you get a lot more data from the sleep image than what an aura can give.
totally. That's completely correct. And I think there's a couple of ways to think of this. One is one could still be a good sleeper but have sleep apnea. Okay. That's not like we don't necessarily think of it that way. We think of it, hey, if someone has a sleep disorder, they have to be a bad sleeper.
Right.
That's not necessarily true. You can be a good sleeper. It's like the individual who snores really loud, their spouse is on their bedside, says, I see this person stop breathing, and they like take these massive gasps in the middle of the night, and like you and I can look at this person and say, like, this person clearly has profound obstructive sleep apnea, but the patient isn't aware of it because they just can sleep through all of this and they wake up in the morning relatively rested. But if we were to do a sleep study, they may have many, many events per hour. They may have sustained low oxygen levels. And this person is at a very high risk of developing AFib, hypertension, stroke, any of these things, years out. So one could be a good sleeper and have sleep apnea, and one could be a bad sleeper and have sleep apnea. So these consumer grade devices, they just tell you what is your sleep kind of like. It's like starting off with an x-ray and you find like an infiltrate, but like, what is that infiltrate? Is it cancer? Is it pneumonia? Is it inflammation? Like, what is it? I need to do now a high resolution CT or just a general CT scan of their chest to get a better understanding of what's going on. A sleep study, I would think of it that way, that if there is any symptomatology concerning for sleep apnea or a sleep disorder, even if their device tells them, their consumer grade device tells them that their sleep is okay, I think they deserve a sleep study, because you might find something that is not necessarily being caught, whether that's movement, it's respiratory stuff, heart rate issues that don't get caught by these consumer grade devices.
And what are some of the symptoms that people can have if they have sleep apnea and don't know it? Like afternoon fatigue, or like what are some of the symptoms that are a red flag that a person might have sleep apnea?
Red flags are excessive daytime sleepiness manifested in, and that could be manifested in a variety of different ways. And, that could be excessive fatigue during the afternoon. It could be you get home and you unintentionally fall asleep. You're not able to really make it to the bedroom. You have dinner, watch TV, unintentionally fall asleep on the couch. Like, that's not really normal. So excessive fatigue or sleepiness during the day, brain fog when you wake up, not feeling rested when you wake up, or if at nighttime you have some level of difficulty with maintaining sleep. Like you have multiple awakenings at nighttime, either to use the restroom or you wake up and you can't go back to sleep. These are all the symptoms that are red flags of sleep apnea. But then you also have like a whole host, you have like separate signs that you and I as a clinician can discover. From a cardiovascular standpoint, they may have like refractory or resistant hypertension. They're on 2 or 3 or 4 different drugs. Or they have very labile diabetes where it's just like blood sugars are fluctuating all over the place. They may have insulin resistance, obesity, metabolic syndrome. They may have had like a TIA or a stroke in the past. So these are all like clinical signs that you and I as a clinician would pick up, but from a symptomatology standpoint, what I discussed with you, those are probably relatively encompassing of one of the main symptoms.
And what are some of the tips that you recommend for patients that are just wanting to improve the quality of their sleep? Like what sleep hygiene type basic tips would you recommend for people struggling with sleep?
First of all, I would say, like, I always like to ask the question, like, why are you not sleeping well? Before giving any recommendations and like assuming that their sleep is reasonably healthy. The recommendations actually start from the time you wake up, and like having a consistent wake up time is like critical. Getting an ample amount of sunlight is critical, and the way to think of this is like there's two sort of processes at play. One is like this like sleep drive process. The longer you're awake, the faster and the heavier you will sleep. The other process is the circadian rhythm process. Like, we all have a biologic day and we have a biologic night. And this biologic day and night is controlled by light and darkness. So as soon as you wake up, you want to get an ample amount of sunlight. You want to have a consistent wake up time. These are all tools that entrain our circadian rhythm. You want to mitigate the usage of caffeine at least 6 to 8 hours before your habitual bedtime. People who exercise during the day, they sleep better at nighttime as compared to people who don't exercise. And then in the evening hours, you don't want to eat too late, close to bed. You want to abstain from excessive alcohol consumption. You want to make sure you're mimicking an environment of darkness in your home that simulates what is happening outside. Again, these are circadian rhythm driving interventions. And then before you go to bed, you want to have some kind of a wind down routine. Nowadays, like, our lives are so busy between our phones and television and like all these other responsibilities. So having some kind of a wind down routine that is 30 minutes, 45 minutes, an hour, if possible, before you go to bed. I think these are all helpful. And then once you get into bed, then it's like the whole idea: make sure your room is dark, it's cold, make sure your room is reserved for sleep and sex only, and it's comfortable. And then if you do happen to wake up in the middle of the night, you want to make sure that you don't engage in activities that are conducive to wakefulness. Like if you do have an awakening, even if it's brief, you don't want to like go to your phone and start watching YouTube, or like go to the television to go watch something. So I think it's like a multitude of things,
Right.
but these are all like very basic things that I think anybody can incorporate into their life.
Well, I wanted to show you one of my hacks. I use these blue light blocking glasses starting around 6 o'clock at night.
Uh,
And these are big enough to go over my regular glasses. So
oh, nice.
if I have to keep working, which I usually do, I try to put these on, and it immediately makes everything very mellow. And
Nice.
I start to get sleepy really fast. But I can still read and everything. But a lot of my functional medicine practitioners, whenever we're on a call together after about 6 p.m., we all have on our blue light, and it's really funny.
Yeah.
Um, and then another thing I've been doing that's been helping is, have you heard of the Apollo
Oh,
Neuro?
yeah. Yeah. I've
Okay.
heard of this. Yeah.
So I've been doing this for about 2 weeks, and I really love it. Like, it syncs to an app on your phone, and I can choose like during the day, right when I wake up, it has like an awake, like vibrations. And then when I start working, it has focus. And then after lunch, I do focus again. And then in the evening, I do unwind. And then at bed, I do sleep. And it starts to learn your rhythms, and it has what it's called smart vibes. And it'll start
Hmm.
just vibrating according to what it thinks you need at that particular time. When I take it off to charge it, I actually miss it. Like, you get used to it, and then it's like having a little friend like hugging you throughout the day.
Sick.
So anyway, I gave it to my sister for Christmas, and she's had insomnia her entire life. And she sent me a screenshot of her sleep, her aura score, and for the first time in her entire life, she slept for 8 hours.
Oh, wow.
And so I don't know. I'm starting to recommend it for a lot of patients that have insomnia or anxiety, and just kind of doing it as an experiment.
My understanding that this works by modulating the autonomic nervous system and like stimulating the parasympathetic nervous system through vibratory tactile sensation. Like, can you
Yes.
elaborate a little bit more?
Well, that's basically my understanding also. I know Dr. Mark Hyman promotes it. He's like the father of functional medicine. And that's where I first heard about it. So then I started looking at it, and I definitely think it activates your parasympathetic. So it just helps calm you down throughout the day. But then it has a way to stimulate you as well. And one time I had it on the energy one, and I actually felt overstimulated. I had to like
Hmm.
turn it off. So
Interesting.
so it has a way of activating or calming you down, which
Interesting.
which is very interesting. So I think it's a good option for people to try that have tried everything and nothing's working. But
Oh,
uh,
totally. Totally.
um, uh, I just wanted to see if you could talk a little more about your Empower Sleep program, like just explain what it is. I mean, we've kind of alluded to it a little bit.
I guess I'll just share my screen. The way the program works is patients will receive a home sleep testing device. Traditionally, laboratory-based studies look something like this. Okay, it's a very tedious process. It's extremely, extremely formative for the doctor to diagnose a problem, but it's difficult to scale. It's not convenient, and it's just like only a snapshot of information. Nowadays, there's a ton of different like home sleep testing devices. Some go on the finger, some go on the chest, some go on underneath the nose. Whole variety of things. We use many of them. The one that is used in this program is this sort of ring-based device that goes on your finger. And the idea is to get some data, analyze these things on a daily basis so that there's a closed feedback loop system and make and see these results in a understandable, digestible way to make changes to behaviors, to incorporate different therapeutic modalities, to modulate these objective numbers. It's kind of like a patient with diabetes using a continuous glucose monitor to optimize their metabolic and glycemic health. What's going to work for them? Is it metformin? Is it a dietary change? Is it exercise after eating something? Is it the elimination of rice? It's kind of a mystery, right? Because everyone's sensitivity to glucose is different.
Right.
Similarly, how our sleep changes and how it responds to different external stimuli is different. So having data across many nights becomes very helpful. And the way the program works is like you get this ring and you test over a period of time. And if you're working with Dr. Engels, she'll give you feedback through these telemedicine visits of what to do, what not to do. And then using that information, the whole idea is to get someone over a period of time to substantially healthier sleep. I think the really positive thing is they're definitely not beautiful, these rings, and they're not as comfortable as an Aura ring. They're way more clunkier, but it's way better than doing a sleep study in a lab to understand what's going on. And I think if we compare these tools to the other option, which is an in-lab study, it's way better, way easier, much more intuitive, much less friction.
Well, one thing I noticed is I had to put it on my thumb because it's kind of a big ring and it would fall off my index finger. So if I put it on my thumb, it would stay all night long. And the only thing that bothered me was the red light. If I turn, I could see the red light and that would kind of wake me up. So you could put like a sock over it or something to like block that light.
Totally.
And right now,
Yeah.
my husband's using it, so every now and then he'll turn over and that red light will get flashed on me. But you get used to it after a while. I also like to wear the Aura at the same time and then kind of compare the data the next day.
Yeah, yeah, many of our patients are doing that. And the other sort of thing that many of our patients have been doing is getting a week, 10 days of data with a home sleep testing device and overlaying that with their Aura Ring data. It gives them some kind of an index of, okay, my sleep is healthy. This is what my Aura Ring data should look like. So now that when I stop testing, this becomes an idea of like where do I stand from a sleep health standpoint. And if there's a deviation in that, then it is a cue to, hey, maybe like something else has changed. My CPAP is not working. My medications aren't working. My hormones are changing. Something could be going on, and these can act as like cues and signals to get evaluated again.
Well, and one thing I like about this 30-day program is after about 3 days of the patient getting their data, I get a notification that their data is available, and then I set up a peer-to-peer consult with you, and you help me analyze their data and decide, is this moderate? Is it mild? Is it severe? And are they a candidate for some of the non-invasive treatments, or do they really need to go straight to CPAP? And then that way I can call the patient and tell them all the options, and they still have more than 20 days left with the ring. So if they want to try the nasal strips or the mouth taping or some of the less invasive things, they have time to do that and experiment with it to see if their sleep improves. Like, for example, my husband has moderate to sometimes severe sleep apnea. And one thing we learned with him doing this is when he drinks alcohol, he has severe. And I've always told him to cut back, but he never would. And then now that he sees this data, he's significantly cut back on alcohol. And he also he purchased the Bongo nasal device that you talked about earlier. And we're still trying to figure out if that's giving him better scores. He's half the time he rips it out in the middle of the night, and then it's hard to know. But I think he really needs CPAP, but he's just trying to, use all the other things first and then decide. But it's really helping me convince him because I've been worried about his sleep and his snoring for a very long time. But just me telling him I'm worried about it was never enough for him to make any changes. But now that he wakes up and he sees the data and sees the impact of that alcohol really affected him, that is getting him to change. And so I'm very grateful for that because I can't get him to change.
Yeah, and I think this is an opportunity to make a distinction. There's a difference between snoring and sleep apnea. And many times we think that they go hand in hand or it's a cosmetic problem is what sometimes people think of it as. And when patients or anybody actually sees like these visual drops in oxygen saturation dropping to 70, 80, 85 many times an hour, that does become like a wake up call, like, oh, it's not just the cosmetic problem of snoring. My heart, my brain is not getting enough oxygen during this like window where I'm supposed to be resting and recovering, and this housekeeping process is supposed to be happening. And it definitely, like, my observation has been, it helps create like a much better closed feedback loop system. And then the other thing is, there was a time when I was in fellowship, we would do a sleep study, and the patient would say, "Hey, dude, this was just like a really crappy night. Like, I don't think I slept very well. I don't think it is like a true representation of my sleep." But now, like, when you can do this across many nights, you can actually see like what are these numbers like across time, and that to me has been like pretty exciting too.
And so, who do you think would be a good candidate for this Empower Sleep program?
I have like a biased opinion here, but that anybody who has any symptoms of a sleep disorder, and I'll sort of like broadly characterize those symptoms with difficulty with falling asleep, difficulty with staying asleep, not waking up rested, or feeling tired during the day. Like any of those like four symptoms, they should probably get their sleep checked out. And anybody who has like a high risk profile from a physiology standpoint, they have hypertension, diabetes, AFib, history of a stroke, obesity, resistant, multi-drug resistant hypertension, like those people should definitely get a sleep study.
I think I've seen some questions coming across in the chat, but someone put, are naps an important part of sleep and rest?
It's a good question, and I think in medicine everything really is like, it depends. Unfortunately, like, there's no straightforward answer, and it depends on the age, and it depends on the reason why somebody is napping. And like the first question that I typically ask is like, why do you feel you need a nap? Are you not sleeping well at nighttime and that's why you need a nap? Or is it just that now you're retired and you have like this opportunity and you can take a nap? Because both of them are very different. I've had patients that we take care of who they are so fatigued during the day that they need to step out of the office and go take a nap in the car. Like, that's very pathologic. That's a red flag. But if you have someone who's relatively, who's retired, uh, had lunch and wants to take a 30, 40-minute nap, and it doesn't affect their sleep at nighttime, that's probably okay. So I think it just kind of depends. If someone is not sleeping well at nighttime, getting that evaluated is probably the most intelligent first step.
Okay. And then, how does the gut microbiome affect healthy sleep?
Yeah, I don't know. That is the honest answer. There's a lot of noise in this gut microbiome space. How this affects sleep is, I think, we don't entirely know. What I can say for sure is if people who have gastrointestinal disorders like reflux disease, peptic ulcer disease, those people can have more arousals in sleep at nighttime as compared to people who don't. And there is probably this relationship, not necessarily causal, but associative, between IBS type of a symptomatology, anxiety, and people who have like chronic insomnia. So I think there's something there, but
Right.
like microbiome specifically, I sort of don't want to
Yeah.
comment on that.
Yeah. I know for myself, if I ate something that wasn't great for me and then I have a lot of bloating that night, I notice my sleep scores are a lot worse and I definitely don't get into deep sleep and I'm getting up multiple times during the night and things like that. So I'm sure an unhappy microbiome is going to directly impact sleep quality. And then someone else asks, are patients able to choose which CPAP device they can tolerate well, like through your program? Or like if you determine they need a CPAP, how does that work for a patient?
Everybody starts off with a regular auto CPAP, unless if they have some condition, and most of the patients don't, obesity, hypoventilation, Down syndrome, like, we'll be able to figure that out in the visit very quickly. But most patients will do well with an auto CPAP. We only use one kind, and it's the best that's available by a company called ResMed. And we use devices that are connected to the internet. Some devices have like a little SD card that goes in them. We don't use those because we're not able to see what the CPAP is doing. We only use devices that are cloud connected. So ResMed, auto CPAPs is what we use. If we need to use like a BiPAP type of a machine, a bi-level machine, that's something that we can use. If someone needs an ASV type of a more complex sort of a ventilator, we're probably not the best fit for them. We can definitely like quarterback their care and be their sleep doctor and sleep clinic, but we're most likely going to be referring them to a local sleep lab to do a more comprehensive titration sleep study to understand what's going on.
Okay. But you can manage the ResMed CPAP virtually.
Yeah, we can manage the ResMed CPAPs virtually, the Philips CPAP virtually. There's a company called ResVent. We can manage those as well. Most of these tend to be connected to the cloud, but I personally like just using the ResMed devices. And we have an integration with ResMed. So like all that data that is sitting in the CPAP machine that gets sent directly to Empower Sleep 2 so their doctor can review it.
Okay. And while they're using the CPAP, are they also still using the sleep image device? So does
Yeah.
the sleep image device give additional data that the CPAP does not?
Exactly. That's the whole idea. Is like, someone might start using CPAP and we don't know if they're actually sleeping better. We assume that they're sleeping better, but we don't know for sure. And doing a sleep study using the ring or any other tool confirms like, is this person actually objectively sleeping better and subjectively feeling better? And so it allows us to titrate the machine settings to that individual from a pressure, temperature, humidity, mask, all of these different sort of permutations that are available on any kind of a CPAP machine.
Okay. Because I have a lot of patients that have CPAP and I talk to them about this program and they say, I don't need that because my machine tells me about my sleep, so I don't need an additional device or something like that. But they're still complaining of fatigue and things like that. So I'm trying to convince them that they do need to do this for a month, but not everyone understands the difference.
Yeah, no, it's a valid point, and because sometimes what happens is we may fix breathing, but it comes at the cost of destroying their sleep.
Right.
But objectively, I would not know that if I don't have a sleep study without CPAP and a sleep study with CPAP.
Mm-hmm.
If I see someone who sleep gets destroyed or sleep quality is worse, deep sleep is less on CPAP than without CPAP, then I start thinking, is it like a CPAP setting issue that needs to be addressed from a pressure, temperature, humidity, mask, EPR, like that standpoint? Or do we need to choose a different modality, like a dental appliance, surgical evaluations, bongo, Excite OSA? Is there something else that we need to look for that could be fixed breathing and also improve their sleep quality?
Right, right.
And the ResMed
Okay.
device, all that tells you when you wake up every morning, they'll give you a happy face around is there any leak or not, or how much leak does someone have? What's the usage of the device, and what the machine thinks are residual sleep apnea events. So it doesn't like really tell you anything about sleep. It's just usage, residual events, and leak. Like how much leak is sort of coming off of the mask and whatnot.
Right. Yeah, because one thing, when I've sent people to local sleep doctors and they get a CPAP and then they come back to see me, they tell me, I don't know if my machine's really working and the doctor doesn't really evaluate me. And like they don't get a whole lot of feedback as far as once they get the CPAP machine, is it really helping them or not? So I feel like your program is much more personalized and precision type medicine rather than just throw a CPAP at someone and say, good luck with that. See you in a year or whatever. That's kind of what happens around here when I send people to local doctors.
That happens 95% of the
Yeah,
time.
right,
even
right,
in, even in really good cities, unfortunately, and it's not their fault, right? And it's not in the guidelines yet to do sleep testing on CPAP. And it's one thing to be like guideline centric of
right.
sticking to the rules and following the rules, and it's one thing to be science centric. And one of the things that was like really ingrained into my head when I did my sleep medicine fellowship at Harvard is like we need to be science centric. Guidelines will always be 10, 15 years 20 years behind, because the way guidelines work is like around this idea of do no harm. It's
Right.
not necessarily around do good for the patient. It starts
Right.
with do no harm. And the thing about sleep medicine is like it's relatively low acuity, and sending somebody a home sleep testing device and having them check on a continuous basis, and just letting the physiology dictate what's working and what's not working is pretty exciting and pretty powerful.
Yeah. I see one more. Someone asked about, does melatonin at night affect deep sleep or optimal sleep?
Yeah, it's a good question. In theory, the way melatonin works is it amplifies the biologic night. And what that means is like we have a biologic day and we have a biologic night. The body has a daytime and the body has a nighttime. Melatonin at the right time will amplify the body's nighttime. And what happens as a byproduct of amplifying the body's nighttime is that you might have more REM sleep and you could possibly have more deep sleep. It should not be used for that purpose. Melatonin should be used in healthy individuals primarily for shifting one's circadian rhythm earlier or later. So, like jet lag is a very clear indication where melatonin is like hyper effective.
Mm-hmm.
But melatonin has many problems. One being because it falls into the category of supplements, the amount of adulteration that happens in melatonin, and this is published, many, the Canadians have published it, the Americans have published it. If a tablet says it's 1 milligram of melatonin, it may have a standard deviation of anywhere from like negative 70% of what they say is in the pill to up to like 300, 400% more than what is in the pill. So we say like, hey, take 1 milligram of melatonin. It's kind of like saying, good luck. I don't know how much you're taking. You might not be getting any, or you might be getting like way more. So it just depends. I think the clinical context depends. I don't recommend using melatonin unless if it's for jet lag, or like sometimes like I'll take it where I've kind of gotten into this like routine of going to bed later and later and later, and like my circadian rhythm is getting shifted a bit more than I wanted to, and I'm waking up in the morning a little bit more tired, both because of sleep debt as well as I'm waking up in the morning and it's still nighttime for my body. In those situations, to like shift my circadian rhythms, I'll take some melatonin, and ideally you want to take prescription grade.
And do you take that a few hours before your optimal bedtime, or
Yeah,
do
you
you?
want it.
Yeah.
Yeah, good. Thank you for bringing that up. You want to take it about 10 hours before your goal wake up time for shifting purposes.
Uh-huh.
Okay. Taking melatonin in the middle of the night because you can't sleep is only going to cause more phase delay the next day, and it's going to cause perhaps some kind of a hangover effect. You're basically gonna wake up in the middle of like your body's nighttime,
Right.
and so you want to take melatonin like 10 to 12 hours before your habitual or goal wake up time. And then
Okay.
when you do that, you want to create like this sort of environment of darkness, something that sort of propagates the body's biologic night, and avoid light as much as you can.
Okay. And is it true that if you take melatonin every day, your body will stop making it, and you'll become addicted to it, or you'll have to take it, or is there a negative feedback, or when you stop taking it, your body will kick back in, or?
It usually does, but it's not ideal. Taking it for a day, 2 days, like, as you're aware, our human physiology has gone through hundreds and thousands of years of evolution, and it's like fairly resistant to all of this sort of battering that we do to it. And a few days of this, a few months of this is probably not harmful, but I think like consistently taking it, like children who start this at a young age, patients or parents give it to their kids, I'm not a big fan of that, because one, melatonin is produced in such uh, small amounts. Like each night we produce like 500 micrograms per deciliter of melatonin. A pill of melatonin is like 1 milligram or 5 milligrams, and like some people are taking like 20 milligrams of melatonin. So like it's produced in such a small amount in a during the biologic night, and there's like such supra therapeutic amounts available, and like you see children taking 1, 3, 5 milligram tablets. I don't think it's a good idea. Short term is probably okay. Long term, I think the story is yet to sort of unfold.
Okay. And then what about, are there any studies with THC gummies or marijuana gummies, CBD gummies, or CBD, whatever, for sleep?
Yeah, I think again it depends on what's the driver of this. If we look at all comer data, taking these THC, CBD in like relatively healthy people who have insomnia, they may be able to fall asleep faster, but their sleep is more fragmented and their quality of sleep is usually not as good. But that's a different scenario than someone who has chronic pain, chronic anxiety, and the pain and the anxiety is what's driving the insomnia.
Right.
That's a completely different scenario, and I think like these things get clumped together. It's our responsibility as clinicians to figure out like what's the driver of this problem and like how do I target those things individually.
Okay. Okay. Well, I think those are all the questions, and thank you for spending an hour with us. That was very helpful. If you want to get more information about the Empower Sleep program, we're going to do a special. So if you mention this webinar when you sign up, you can get $99 off the month program. Email the office or give us a call and tell us you heard about it, and we will honor that. I will be in touch with you soon to go over other patients' data, and thank you so much for your time.
Yeah, thank you guys.
All right.
Bye. You too. Bye.
Okay. Bye bye.